Hello boys and girls, welcome back to Cardiac Academy. In this video, we're gonna dive into our very first point of care echocardiography video. So today is all about the Parasternal Long Axis View. So buckle up because we're going for a ride. Okay, let's get started. All right, so before we begin, we need to talk about the basic sonographic windows. So today we're gonna talk about the Parasternal Long Axis View, but we also have to be familiar with other views. So the basics ones are the Parasternal Long Axis View, the Parasternal Short Axis View, the apical first chamber view, and the subxiphoid view, all right? In this image, we can kind of summarize all these views together. And as you can see, each one of these views are gonna have a special view of a certain part of the heart, all right? So today is the Parasternal Long Axis View, which is the one in the upper left corner, all right? So when we use the ultrasound machine, you're gonna notice there are different probes or different transducers. So the most commonly one used is the linear probe, which is this one over here. And the linear probe is usually used for vascular access, like when we're putting a central line. But you can also use it for peripheral access as well. Then we have the curvilinear, and the curvilinear is usually used for abdominal ultrasound, like when we're trying to assess the liver. And finally, we have the phase array, which is the probe that we're gonna use on cardiology, okay? It can also be used for ultrasound, lung ultrasound, all right? So the phase array has some benefits, and that's why we use it in cardiology. So the first thing you need to be aware of is that it allows for deeper penetration because it has a low frequency, okay? And because it has a short footprint, it's gonna help us maneuver in between the ribs when we're trying to look at the heart. So there are also gonna be important aspects on how to do this. There are techniques, and we're gonna go into them right now. Okay, so each probe has a probe marker, and the probe marker, it's this little dot that you can see here, and that's gonna help us orient ourselves when we're trying to look at anatomical locations. Likewise, on the monitor, you're gonna see a probe marker or an indicator, just like we see right here. In this case, it's our Cardiac Academy logo, and that also is gonna help us orient ourselves. So by convention in echocardiography, that indicator should be on the right upper corner. Otherwise, when I tell you how to access these windows, if that indicator is not on the upper corner, it's on the left, then everything's gonna be inversed, okay? So we have the probe marker, that little dot on the probe, and then we have the indicator, which is gonna be on the upper corner of the screen, okay? All right, so let's get started with the cardiac mode. So on ultrasound machines, you're gonna see often that you can switch between abdominal ultrasound, between vascular ultrasound. So for us to access the heart, it should be done on cardiac mode, okay? So just make sure that your ultrasound machine is on cardiac mode, all right? Next, our patient should be positioned correctly. So ideally, we want our patient for Parasternal Long Axis View to be lying on their left with their left arm behind their head, just like we see here in this image. So as you can see, that is gonna help kind of spread the ribs apart. So when you are using your probe, you won't have as much shadows from the ribs, and you're gonna have a better picture, okay? Likewise, the position of our probe is also important. So just like I said, each probe has an indicator, and that's gonna help us orient ourselves, okay? So for the Parasternal Long Axis View, that little dot, which is supposed to be right here, should be looking at the right shoulder, okay? So you're gonna look at the left parasternal border, around the 3rd to 4th intercostal space, and then that little dot should be looking at the patient's right shoulder, just like in this image. You see this arrow is looking towards the right shoulder, all right? And that's gonna help us find that Parasternal Long Axis View. Okay, let's talk about anatomy. So whenever you're looking at an echocardiogram, the first thing you should do is try to identify anatomy, right? So when I look at the parasternal long axis view, I like to start first by looking at the left atrium. So right here, we have the left atrium, and just distal to it, we see the anterior leaflet of the mitral valve right here, and the posterior leaflet of the mitral valve right here. Once I identify the left atrium, then I go ahead and look for the left ventricle, which we can see right here. And on top of the left ventricle, we have the interventricular septum, which is right here. And it divides the heart into left ventricle and right ventricle. So on top of it, we have the right ventricle. Okay, very good. Next, there's another anatomic land point that is important to look at, and it's the descending aorta, which we can see right here. Okay, and we're gonna see later why it's important. And finally, we also have the aortic valve, which we can see right here. All right, and we'll go into more detail as we progress, but we can also see here the lining of the pericardium, this kind of echogenic membrane right here. So that's the pericardium, okay? All right. So now that we practiced with the anatomy, let's try to identify the anatomy on a moving heart, okay? So we approach it the same way. First, I like to look at where's the mitral valve and where's the left atrium. So it's easy to identify the left atrium because we're gonna see the mitral valve moving. And we can actually see the mitral valve right here, the anterior leaflet. As you can see, it moves up and down, and it approaches the interventricular septum. That's the anterior leaflet of the mitral valve. And then we have the posterior leaflet right here. And since that's where the mitral valve is, that makes this the left atrium. Left atrium. Then more distal to the left atrium, we find the left ventricle. So this is the left ventricle. And on top of the left ventricle, we said earlier that we have a septum. Which septum? The interventricular septum, right? So ventricular septum. And on top of the interventricular septum, we have the right ventricle, I'm sorry. By the way, we can't really see the right atrium in this view, okay? And we have the descending aorta right here, and we have the pericardium right here. And finally, the aortic valve is right there. All right, very good. So as we said earlier, here we have both the pericardium, which is the echogenic membrane right here, and we also have the descending aorta. And these two landmarks are important to identify because they're going to help us differentiate whether we're dealing with a pericardial effusion or a pleural effusion, okay? And we'll see how. Okay, let's take a look at these two examples. So in the first example, on your left, we can first, like we said, identify the descending aorta, which is right here. And then we look for the pericardium, which is right here. And then we ask, is this fluid that we're seeing right here anterior or posterior to the descending aorta? So in this case, we can see that it's anterior to the descending aorta. So if the fluid is anterior, that makes it a pericardial effusion, okay? So this is a pericardial effusion. Then on the second example, again, we look for the descending aorta, which is right here. And then we look for the pericardium, which is right here. And again, we ask, is this fluid anterior or posterior to the descending aorta? And in this case, we can see it's actually posterior. We can see the fluid here. So since this fluid is posterior to the descending aorta, this makes it a pleural effusion, okay? So this is a pleural effusion. By the way, we have here, this is a collapsed lung, okay? So that's the way we do it, okay? First is if you notice any fluid, look for the descending aorta. And after you identify the descending aorta, look for the pericardium. If the fluid is anterior, it's within the pericardium. If it is posterior to the descending aorta, it's a pleural effusion. All right, good. Another example. Again, we look and we see some fluid, right? We see some fluid around the heart. And we can see some fluid here. Let me change color to make it easier for us. So I'm gonna choose blue here. We see some fluid here. But we also see some fluid up here. Okay? So we look for the descending aorta, and it's right here. And then we ask ourselves, is this fluid anterior or posterior to the descending aorta? And it's anterior to the descending aorta. So this is a pericardial effusion. Now, there's something important about this image, and it's that we don't only see fluid anterior to the descending aorta on the left ventricular wall, but we also see some fluid in the right ventricular wall. And we can actually see a little bit of that ventricle being slightly compressed. You look here, you can see how that wall is bouncing up and down. So we're seeing here right ventricular compression, which is early stages of tamponade. Okay, very good. So just like we said, there's a chaotic movement of the right ventricular wall, which could suggest early stages of tamponade. All right. So let's take a look at this other example. And again, we see some fluid here, and we see some fluid up here as well. We'll look at the descending aorta right here. It's anterior to the descending aorta, so that means this is a pericardial effusion. And we look at the right ventricular wall, and we see that this time around, it's not only the chaotic movement, but we also see that it's actually getting much more compressed than in the previous image. So in this case, we can actually call this possibly tamponade, okay? Now, remember, cardiac tamponade is a clinical diagnosis, okay? So the only way to really confirm that you have a cardiac tamponade is with improvement of hemodynamics after pericardiocentesis, okay? All right, but we have a question here. So what are the classic physical findings of cardiac tamponade? Okay, so we have Beck's triad. So what is Beck's triad? We have hypotension, increased JVP, and muffled heart sounds. But in addition to that, we can also see other findings, like you're gonna have reflex tachycardia. Just think about it. When you have hypotension, for your body to maintain cardiac output, you develop reflex tachycardia. You can also have cool extremities. And finally, you have pulsus paradoxus, which is a decrease in blood pressure of at least 10 millimeters of mercury during inspiration, okay? All right, we also can see some EKG findings, and since this is a cardiology channel, let's take a look. All right, so the first thing you will notice is tachycardia, just like we said, but you will also see what is called electrical alternance. And electrical alternance is just the QRS amplitude is gonna vary from heartbeat to heartbeat. You can see here how it's tall, then short, then tall, then short again. And the reason this happens is because your heart is literally trying to beat surrounded by a balloon of water or a fluid. So your heart is actually swinging back and forth within this bag of fluid, which makes the electrode detect a difference in amplitude with each beat. Additionally, you'll notice that the amplitude of these QRSs are actually shorter than usual, which is another finding, is short amplitude, okay? Then on this next example, we can see, we don't see the short amplitude, but we can see this electrical alternance again. And finally, on the last example, you can see PR depression. You can see how it has like a downward motion, the PR segment. And this can also be seen in pericarditis, okay? Very good. All right. Let's continue. So here we see two chest x-rays. The one on the left, it's a normal chest x-ray in which you can see a normal cardiothoracic ratio, which means that the heart does not take more than 50% of the thorax. So that's a normal cardiothoracic ratio. But if you look at the second example, you can see how the cardiothoracic ratio is actually increases more than 50% of the thorax, and it also has this kind of balloon shape. So you can see how this is a big pericardial effusion, possibly causing tamponade as well. And just like we said earlier, the diagnosis of cardiac tamponade is a clinical diagnosis. So imaging can help with the diagnosis, but the only way to truly confirm a cardiac tamponade is by performing a pericardiocentesis and then having improvement of the hemodynamics, okay? Very good. All right, let's shift into left atrial enlargement. So left atrial enlargement is gonna be there when you notice that the diameter of the left atrium is always greater than the diameter of the overriding aortic root, okay? And we can see that here. Here you have the left atrium, and you can see how it's bigger than the overriding aorta that you're seeing here, the aortic root. So when that happens, then you're sure that you have left atrial enlargement. The correct way of checking for this is during ventricular diastole. However, just for convenience, we just look throughout the whole cardiac cycle, and if it looks enlarged, then you have left atrial enlargement, okay? So left atrial enlargement can happen when you have chronically elevated filling pressures in the heart, okay? And this usually happens when you have chronic heart disease, such as paroxysmal atrial fibrillation, or when you have diastolic dysfunction. And again, you can check in this image. On image number 1, you can see how it's supposed to be normal. You see how the left atrium and the aortic root are essentially the same size, but on image number 2, you can see how the left atrium is much bigger than the aortic root, okay? So in image number 2, we have an enlarged left atrium, all right? So this view is also excellent to check for ventricular dysfunction, to estimate the ejection fraction. So one thing to keep in mind is that a single view is not enough for you to really be certain that you have a reduced ejection fraction or a preserved ejection fraction. You should at least look at 3 different images. You're looking at a 3-dimensional structure. The heart is a 3-dimensional structure, so you should look at least from 3 different views for you to assess a 3-dimensional structure. However, the parasternal long axis view can be pretty helpful, especially when you're doing point of care echocardiography in a patient that is lying on their back, and you're just trying to quickly assess their ejection fraction without doing an official echo. So there's a few things we need to look at, and we'll go through that right now, okay? So let's start with the EPSS. So EPSS stands for early point septal separation. And all we're doing is looking at the anterior leaflet of the mitral valve, which is this one right here. And we're looking how much it approaches the interventricular septum. That is called the E point. So normally, this anterior leaflet of the mitral valve should almost touch the interventricular septum. That's a sign of a good ejection fraction. Of course, if the patient has mitral stenosis or mitral calcification, then the EPSS is not going to be that helpful because the leaflet is going to be moving erratically, or it's going to be more stiff. So it's not going to be a good thing to look at. But we have other options, and we'll go into them a little bit later. So the EPSS can also be measured on M mode and using measuring tools. But since this is point of care echo, we can do it visually, okay? So like we said, the anterior leaflet should approach the interventricular septum, and it should have a distance of less than 1 centimeter to be considered a normal ejection fraction. If it is more than 1 centimeter, then it's a reduced ejection fraction, okay? And we can measure that using a measuring tool on the echo machine, but you can also do it visually, okay? All right. So Here we have two examples. The one on the right, on the left, example number 1, you can see how that anterior leaflet of the mitral valve is barely moving. So this is an example of an ejection fraction of approximately 10%. Now compare that to the one on the right side, example number 2. You can see how that anterior leaflet of the mitral valve is almost touching the interventricular septum. So this is an example of a preserved ejection fraction with an ejection fraction of 70%, okay? All right. So we talked about the EPSS. There's other things we can look at in case someone has a calcified mitral valve. So we can look at the myocardial thickening. And the myocardial thickening just means how much the muscle is thickening during systole. So just like any muscle in our body, when we work out, when you do, like, for example, bicep curls, your muscle gets shorter and thicker. So the same thing happens to the ventricle. And you can see here how it's getting bigger during systole, and then it goes back to normal during diastole. So this is a sign of a good myocardial thickening, how the muscle is getting bigger. And you can also look at what is called the fractional shortening. And fractional shortening, let me just change color, is the distance between the left ventricular wall and the interventricular septum, how much they approach each other. And you can see how much they're almost touching each other, right? So that's a sign of a good ejection fraction. This can also be assessed using a measuring tool and using M-mode. However, like we said, this is a point of care echo, so we can do it visually. Let me just clean this up for you to be able to look at it again. Okay, so as you can see, the myocardium is getting thicker with each beat, and the walls are approaching each other, so we have a good fractional shortening. And finally, we look at the EPSS, and we see how that anterior leaflet of the mitral valve is approaching the interventricular septum. So those are signs of a good ejection fraction, or a preserved ejection fraction, okay? Okay, so let's take a look at this other example. So first, let's assess the EPSS. So we look at the anterior leaflet of the mitral valve, and we look how much is it approaching the interventricular septum right here. And we can see that it's barely approaching it. So that's a sign of a poor ejection fraction or a reduced ejection fraction. Then we look at the myocardial thickening, and we look at the muscle, and we can see that it's barely changing from systole to diastole. So there's a very poor myocardial thickening. And finally, we look at the fractional shortening, and we look at the distance in between the left ventricular wall and the interventricular septum. And it should approach each other with each beat. And we can see that it's barely moving. So in this particular case, we have a very poor ejection fraction, okay? And as we learn, I want you to keep this either poor ejection fraction or good ejection fraction or preserved ejection fraction. And then as you become more experienced, then you can start assigning a percentage to that ejection fraction. But for now, I want you to just be able to look at that echo and be like, this is a good ejection fraction or a poor ejection fraction or a preserved ejection fraction or reduced ejection fraction, okay? But in this case, this is probably close to 10% ejection fraction, okay? All right, let's continue. Now, let's take a look at this example. First, EPSS. What do you look for? The anterior leaflet of the mitral valve, correct. And what do you want that leaflet to be doing? You want it to approach the interventricular septum. And we can see it's approaching it very well. It's almost touching the interventricular septum. After that, what do we look for? Myocardial thickening, right. So, and we look at that muscle, and you can see how during systole it's getting much more thicker. So that's a good myocardial thickening. And finally, we look at the fractional shortening. And we look at the left ventricular wall and the interventricular septum, and we want both of those walls to almost approach each other, almost touch each other. So they should approach each other, okay? So this patient has an excellent ejection fraction. This is more than probably 60 to 65% ejection fraction, okay? Very good, excellent. Now, let's take a look at this other one. Again, EPSS. Look at the anterior leaflet of the mitral valve right here. Is it approaching the interventricular septum? It's not. That's a bad sign. We look at the myocardial thickening. Is it getting any thicker during systole? It's not. That's a poor sign. Then we look at the fractional shortening. Are the walls approaching each other? And they're not. This is a very poor ejection fraction, okay? So this is probably closer to 10% ejection fraction. All right. And just like we said, remember, it's not enough to look at a single view and conclude that you have a poor ejection fraction. You should look at least 3 different views so you can assess a 3-dimensional structure, okay? All right, my friends, that's it for today. Thank you so much for watching this video. Please like, share, and subscribe. And as always, I'll see you back at the Cardiac Academy.